My name is Dr. Yoonseok Oh, and I'm working as a specialist dermatology in Abu Dhabi, UAE now. Sensitive skin is not kind of medical term. It's a subjective symptom that patient complains when they visit the clinic. So it was hard to define sensitive, what exactly the sensitive skin is. But recently, according to one forum, International Forum of the Society of Itchy, has defined sensitive skin, and they define as follows. Uh, a syndrome defined by the occurrence of unpleasant sensation. This unpleasant sensation includes stinging, burning, pain, pruritus, and tingling sensation in response to stimuli that normally should not provoke such sensation. These unpleasant sensations cannot be explained by lesions attributable to any skin lesion. This means usually the stimuli does not provoke any symptom, and the patient who complain sensitive skin has mostly normal skin. I mean, this kind of symptoms cannot be explained by other skin disease. And these sensitivities can affect all body location, especially the face. Clinically, to diagnose the symptom, it's not easy because, as I explained before, it's kind of a subjective symptom. Occurs on normal skin phase. So before, we had used lots of methods to diagnose it. As you can see in the table, we use lactic acid and see if the patient complains stinging sensation after a certain period, or we use capsaicin or sodium lauryl sulfate. This sodium lauryl sulfate is kind of cosmetic preservatives commonly used in cosmetics before, and other method called cross-polarized light or the scanner or SIBO tape. All of these diagnostic method is not easy to perform clinically in the clinic. Researched how many people suffer from sensitive skin. There is one study conducted in Korea 2017. We asked around 1,000 people. You can see in the table that around 40% of patients reply that they have very sensitive skin, and then 42.6 patients reply that they have sensitive skin. It means over around 57% of the people say that they have sensitive or very sensitive skin. It's interesting that more than half of people, normal population, complain that they have sensitive skin. And you can see this one according to age group. In younger group, less than 44 years old group, around 64% of people say that they have sensitive or very sensitive skin. Relatively older group, above 45 years old, they reply that only 48% of them have sensitive or very sensitive skin. We also surveyed if sensitive skin is related with other skin disorders. Around 73 and 72% of very sensitive and sensitive skin group answered that they have another skin disorder on the face. And these skin disorders were acne, atopic dermatitis, seborrheic dermatitis, and facial flushing. Acne, seborrheic dermatitis are common disease group of oily skin, and facial flushing is typical sign of rosacea. And as you know, atopic dermatitis is the typical disease of dry skin. It means that the sensitive skin can happen both in dry skin group and then oily skin group. Why does the sensitive skin happen? How can we explain about the pathophysiology? Sensitive skin has two kinds of mechanism. The first one is disturbed barrier. I'll explain about the barrier later, but basically sensitive skin group has impaired skin barrier, and it's shown in atopic dermatitis and rosacea, also in other kinds of skin disease. And another mechanism is neurogenic inflammation. We cannot control this neurogenic inflammation without medication. We can just try to modify our lifestyle. But if it's not controlled, then we need to get help from the medicines or medical devices. There are other contributing factors such as air pollution, climate, heat or wind, and sun exposure, or cosmetics, or physiological factors. What is skin barrier? Skin barrier is also known as dermal permeability barrier, dermal barrier, and then stratoconium barrier. And if you see the picture on page 8, this is skin diagram, and skin consists of upper surface called epidermis, and then under the epidermis there is the one called dermis, and then under that area subcutaneous layer, and under that layer it's musk layer. And the epidermis layer is the outer surface of the skin, and it has 5 layers. You can see only 4 layers in this diagram, but on specific lesion, there are 5 layers. Most bottom layer is called basal layer, and the cell called keratinocyte differentiate from this area to the upper side. And the most upper area is called stratum corneum. Was regarded as a dead skin cell before, but these days, this layer became important physiologically and biologically in human body. On page 10, you can see electron microscopic picture of stratum corneum, the outer surface of skin barrier, and under this area you can see stratum granulosum. The interesting thing is on this stratum corneum area, it has a layered structure. So before, in 1960s, we thought this area is not important. It's just kind of dead skin cell and desquamation area. Up to 1975, it's just tough, resilient, and impermeable area. But after 1980s, this stratum corneal area has regarded as structural and biochemically important thing. It has persistent metabolic activity, and it is the region that interacts with underlying tissues. 1980s, they introduced new concept called brick and mortar model on this stratum corneum area. And you can see this electron microscopic picture that is brick means corneal site, the dead skin cell, and then mortar is this layered structure, means extracellular lipid. You can see the picture B that there is corneal site, and then you can see that there is empty space on astronaut area, and it's impaired lipid. There is no proper lipid component. In this brick and mortar model, mortar acts as a permeability barrier and antimicrobial defense, antioxidant defense. And brick, that means the corneal site acts as UV barrier, mechanical barrier, and hydration. In this stratum corneum lipid, lipid called ceramide consists of the highest percentage. It consists of around half of total lipid, and another composition is cholesterol and free fatty acid. So let's see skin barrier abnormality in atopic dermatitis, because atopic dermatitis is kind of severe eczema, and it's the typical disease of dry skin. In this atopic dermatitis, dry skin is the most common skin problem, and it shows elevated transepidermal water loss, and then low volume of ceramide. Even on involved skin, it shows increased transepidermal water loss and then low volume of ceramide. It means that it's really important to apply moisturizer on both affected area and unaffected area. Dry skin in atopic dermatitis happens, as I explained before, the ceramide is the most important lipid in stratum corneum structure, and as it's decreased, skin barrier impairment happens, and this causes increase of TWL and then decrease of water holding capacity. So it causes increase of ectodermal keratinocyte lifestyle. It makes keratinocyte differentiate quickly, and it causes dry skin on the outer surface area. Back to the sensitive skin. This sensitive skin also happens in oily skin as well. Typical disease of this oily skin is acne and rosacea, and there are also other symptoms that shows stinging and allergic type. And also in oily sensitive skin type, they show altered sebaceous lipid composition. And this is one of the reasons why it causes sensitive skin. The reason of oily sensitive skin has several kinds of theories. It's a bit different from the dry skin. In oily skin, the sebum lipid is different from stratum corneum lipid composition. Around more than half consists of triglyceride and free fatty acid, and there is no ceramide, but small composition of wax ester and squalene and cholesterol. When you assess the patient with rosacea, there is also altered lipid composition, increase of nitric acid, and decrease of fatty acid. So this is one of the theory why sensitive skin happens even in oily skin. How can we manage this sensitive skin in clinic? The treatment of sensitive skin is not easy because most of the patient comes without skin lesion, just comes with the subjective symptom. So the most important thing is the individual trigger factors should be avoided, such as heat or cold or air pollution or long-term sun exposure, or also kinds of other contributing factors such as cosmetics or foods or alcohols. And another thing that helps the patient is topical therapy, so we can recommend mild non-irritating ingredient cleansers or moisturizers to the patient. And sometimes this kind of solutions is not enough. In that case, patient should come to the clinic and ask dermatological advice. In this case, most of the doctors prescribe topical steroid, topical cortisol, to reduce the symptoms quickly. But the problem is we cannot use the topical steroid for a long time because, as we know, it has lots of other kinds of side effects. Uh, Sometimes we change it into other topical medicines such as calcineurin inhibitor called pimecrolimus, or we combine low-level light therapy, or we recommend probiotics. The common side effect of topical steroid is skin atrophy, skin thinning, and telangiectasia, the red vessels, and it increased the possibility of skin infection if we use for that long time. And even with the short-term use, it impairs skin barrier. Then how can we manage this sensitive skin for long term? One of the most important thing is proper moisturizer. So I have used many kinds of moisturizers in this case, such as Johnson & Johnson baby lotion, rock hydrogen lotion, Cetaphil, Physiogel, and ZEROID. There are lots of moisturizers in the market. As you can see in the table, white 3 moisturizers called Triceram, Physiogel, and ZEROID has ceramide component. You can remember that the ceramide is the most important lipid structure in stratum corneum area. For ideal moisturizer, there should be ceramide component. As we saw before, the composition should be more than half of the total amount. The advantage of this ZEROID cream is it consists of multilamellar emergent structure. Before you saw that the epidermal lipid has a layered structure, and it's important to make this lipid composition into this layered structure to recover the impaired barrier quickly. We compared ZEROID cream and then other topical moisturizer after disrupt the skin barrier by tape stripping. And if you see the picture on upper side, this one is after applying ZEROID cream, and you can see that the layered structure is recovered fully. But on the lower picture, you can see that lipid composition is repaired, but layered structure is not fully recovered. It also shows difference clinically. In 2001, we applied this ZEROID cream, MLE structure, and other normal moisturizer into a different group, and we switched the moisturizer after 4 weeks. We evaluated with the squad score, and you can see on left picture that the group A, they get applied ZEROID cream for first 4 weeks and switch to other moisturizer for following 4 weeks. You can see that this group shows improvement around 30% of squad score at the first 4 weeks, but only 10% improved of squad score after following 4 weeks. And also on group B, you can see that it shows 15% of improvement of squad score at the first 4 weeks when they apply normal moisturizer. Following 4 weeks, it shows 35% of improvement of squad score after applying ZEROID cream. And this shows clear statistical difference. And this ZEROID has another advantage is it has antimicrobial peptide inside called defensamide. This antimicrobial peptide is kind of human innate immunity system, and in atopic dermatitis, it's decreased a lot. So it helps to improve and reinforce skin barrier and the skin defense system against other bacteria and virus infection. There are lots of ZEROID ranges in the market, and you can start from moisturizer, soothing moisturizer, and then intensive moisturizer. If you have another kind of skin disease, such as acne or rosacea, you can try this Improve group. Before, I have used Cetaphil and Physiogel for the atopic dermatitis patient or the patient with other skin diseases. But sometimes patient complaints moisture effect does not last long, or I feel a tingling sensation after applying certain kind of moisturizer. But after starting using the ZEROID cream, it shows really big difference. The MLE structure has a patent in Korea, Japan, US, and Europe, and that MLE structure is approved by the article in Journal of Investigative Dermatology, and so I can highly recommend it because it also has a strong background of scientific evidence.